So welcome to this new session of videos on OSCE. So we know that lately the pattern of the pediatric practical exam has changed, and along with the long case, short case, and the newborn case, there is a lot of emphasis being given on OSCE and table vivas. So we're going to start with a series of small videos where we're going to look at those smaller sections of questions that can be asked in your viva. So the first video of this series is going to be on demographics and history taking. So we know that demographics in pediatric history taking consist of a lot of questions, starting from age, sex, consanguinity, birth order, etc., etc. So a lot of examiners are asking questions on what is the significance of asking each of these questions pertinent to that particular case. And because we know that demographics is that part of history taking which is going to be asked in any of your case, like you will be taking history on demographics, irrespective of whether it's a long case or a short case or a newborn case, or irrespective of what system is involved, let's quickly look at why you need to ask these questions and what questions can the examiner ask you as to the significance of each of these questions under demographics. So the first one is, why do we ask the name? So it helps in correct patient identification. It helps to build a rapport with the patient. So when you communicate with the patient and address the patient by the name, it kind of instills a sense of security between the informant or the kid itself and the doctor. So it helps in better history taking. And the third one is, a lot of names will give you some insight of what the religion could be like, and we look ahead, but there are certain diseases that are more common in certain religions or communities. To give you an example, circumcision is a procedure which is performed in one particular community as compared to the others. So some hint about the religion and the community can also come just from the name. The second question that we ask for is the age. Now, what is the significance of age in history taking? So it's important to remember that different diseases present at different ages. To give you an example, let's talk about hemoglobinopathies. So if you're talking about thalassemia, you have beta thalassemia major and alpha thalassemia major. Now, it's very important to know that, although both of them are thalassemias, they have different presentations, and most importantly, they present at different ages. So let's talk about beta thalassemia major. Important question always asked in Viva, that what is the common age of presentation of beta thalassemia and why? Okay, so beta thalassemia major, which is now called as transfusion dependent thalassemia, presents after 6 months of age. So after 6 months, maybe 6 months to 1 year of age is the usual age of presentation of beta thalassemia major. Whereas if you look at alpha thalassemia major, also called as hemoglobin BARDs, where you have deletion of all the four alpha globin chains. So when we talk about beta thalassemia major, you have deficiency of two beta globin chains, whereas in alpha thalassemia major, you have deficiency of all the four alpha globin chains. So beta thalassemia major usually presents after 6 months of age, whereas alpha thalassemia major can present either in utero or in the immediate newborn period. Now, why is this important and why is there a difference in the age of presentation? So when you look at beta thalassemia major, to understand this, let's just look at what happens in utero. So in utero, you have fetal hemoglobin, also called as HbF, which has two alpha and two gamma chains, right? Okay, so that is the predominant hemoglobin also present at birth, which is a HbF. Now, over the period of the next few months, at next 3 to 6 months, a transition happens from the fetal hemoglobin to adult hemoglobin, which is HbA. Now, HbA has two alpha and two beta globin chains. So what happens at 6 months of age when this transition is supposed to occur? It doesn't, because there's deficiency of the beta globin chains, as a result of which inadequate amount of adult hemoglobin is produced, and that's when you have the presentation of anemia with other clinical symptoms. So that's why you have presentation of beta thalassemia major after 6 months of age. Whereas when you look at alpha thalassemia, if you look at HbF again, it has two alpha and two gamma chains. Now, when we talk about alpha thalassemia major, where there's deletion of all the four alpha globin chains, you will not even have production of HbF because it's alpha 2 and gamma 2 chains. So these patients present with severe anemia, and many of them even die in utero, or they may present with severe anemia in the neonatal period, requiring repeated or multiple blood transfusions. So this is the importance of age. So when you have, like, an 8-month-old presenting to you with the history of repeated blood transfusion starting at 6 months of age, then you will not think of alpha thalassemia major. Similarly, if you have a neonate who's requiring multiple blood transfusions starting from day 3 of life, you will not think of beta thalassemia major as your differential diagnosis. So this is an important example of what is the significance of age in your history taking. Another example would be what is the common age of presentation of a ventricular septal defect or a VSD. So VSDs, large VSDs usually present at 4 to 6 weeks of age, not before that. Why 4 to 6 weeks of age is because that is when the pulmonary pressures start to fall. So if you have a newborn, say day 3 of life, presenting with signs of failure, signs of congestive cardiac failure, you will not think of a large VSD as your diagnosis. You might think of other conditions like it could be coarctation of aorta, it could be interrupted aortic arch, it could be other things. Okay, so that is the significance of age in your history taking, right? Moving ahead with sex. So we all know that X-linked recessive disorders are affect males, whereas females are carriers. So examples with respect to pediatrics, like you have hemophilia, Duchenne muscular dystrophy, G6PD deficiency. All these are examples of X-linked recessive disorders. So in your history, you will see that the males are affected and the females are unaffected. So because females are carriers. Having said that, it's important to remember that it is not that females can never be affected with X-linked recessive disorders. So conditions where you can have females affected with X-linked recessive is when you look at your Lyon's hypothesis, or if you have Turner syndrome where you have deletion of one X chromosome. So these are rare instances where females can be affected with X-linked recessive disorders, but not going into those zebra syndromes. Let's talk about more common things. So when you have, like for example, say an 8-month-old who's presenting with repeated joint swellings and a history of bruising after vaccination, and a similar history of some blood disorder in the maternal uncle, then it's kind of the first thing that should come to your mind is hemophilia, since it's a male getting affected with a significant family history of the maternal uncle, which gives you a history of X-linked recessive disorders affecting males and not affecting females. That is one importance of sex. Another thing is nutrition is more common in girls, especially in our country with neglect and maybe boys given more preference versus girls. Malnutrition is seen more commonly in girls. Third is now vitamin D deficiency, rickets, is also more common in girls, especially those who wear burqas because they have inadequate exposure to sunlight. So that is another example of why sex would be more important. For example, if you have a case of rickets in a girl, this could, be one viva question that can be asked to you. Moving ahead, birth order. So more the children, more the incidence of malnutrition, especially in those who are socioeconomically poor and do not have enough to feed their kids. So that's a broad explanation of why you would ask for birth order. Second interesting example is in case of newborn jaundice. Okay, so let's talk about Rh incompatibility, which happens when the mother is Rh negative and the baby is Rh positive. So we know that Rh immunization affects the second child, not the first child. Why does that happen? This is another exam question. So when the mother is Rh negative and let's say the first baby or first fetus is Rh positive, the mother gets sensitized with anti-Rh antibodies, but it doesn't affect the first baby. Whereas when the mother is pregnant with the second child and let's say the second baby is also Rh positive, those anti-Rh antibodies go and affect or go and kill or go and react with the Rh antigen located on the RBCs of the fetus, causing hemolysis, causing anemia, and Rh immunization. So this is an example of why the birth order would be important, especially in a case of newborn jaundice. Consanguinity, we all know autosomal recessive diseases like hemoglobinopathies, beta thalassemia, enzymopathies like Gaucher's disease, Tay-Sachs are all autosomal recessive, so they run in the family, and that's why history of consanguinity is important, especially when you're dealing with autosomal recessive conditions. Another practically important point is, let's say you have a child who has beta thalassemia major. A very important point in counseling that you will be telling the parents is that when they plan the next child, they should undergo testing, genetic testing of the fetus to see if that child is also beta thalassemia major, because like we know, it's a lot of burden to the child and to the family when it comes to repeated blood transfusions, iron chelation. They might also require bone marrow transplantation, etc. So a lot of complications come along with these chronic illnesses. So prenatal genetic testing is very important and should be emphasized to parents who's already had one child with beta thal major. Now, religion, certain diseases run in certain communities. Like, for example, if you have hemoglobinopathies and beta thalassemia, it's more common in certain communities of our country, like the Sindhis, Kachhis, Bhanushalis, Kolis, Luhanas, and Buddhas. So that's why if you have a child presenting, let's say, with anemia, hepatosplenomegaly, history of repeated blood transfusions, etc., you should always ask for consanguinity and the religion or the community. Vitamin D deficiency in certain conditions or certain religions, I would say, because of inadequate sunlight exposure, like we just discussed. Neurocysticercosis is common in those who consume beef and pork because those cysts tend to remain in those meats. Okay, so these are examples of why religion would be important. And obviously, with respect to your particular case, you can have other important clues to it as well. Residence. So, what is the importance of residence in history taking? Now, for example, PDA and sickle cell anemia are more common in those who live at higher altitudes. For obvious reasons, when you have lower oxygen saturation in higher altitudes, with respect to sickling, it promotes sickling and it increases the viscosity of blood, and that's why sickle cell anemias, those who live at higher altitudes present earlier. Malaria is endemic in certain areas of the country. So let's say a child was presenting with fever, with chills, you need to ask for where they're residing. If you look at this diagram, this is a map showing distribution of beta thalassemia in India, where you have the north zone, the east zone, the south zone, and the west zone. So these are locations where you will have higher bunch or more accumulation of patients who have beta thalassemia in certain pockets. So that's why residence again becomes very important when you're taking a case of hemoglobinopathy. Crowding and communicable diseases go hand in hand. So when you have infectious diseases, let's say tuberculosis, it's very important for you to take history of the residents. So let's say they're living in slum areas, then it's more likely that they are more susceptible to infectious diseases. So that's the importance of residents. Last but not the least, informant and reliability. So usually in pediatric cases, the informant is either the mother, the father, or the grandparents. But you can also have other family members. You can have uncle, aunts, or extended relatives, depending on who is with the child. If the child is old enough, they can give the history for themselves. Now, usually the best person to give you the history is the mother, especially when it comes to developmental milestones, because the mother is one person who tends to spend maximum time with the child, and she's the one who will be able to give you the history the best. Having said that, it's not compulsory that it has to be the mother. Even other family members are welcome to add on to extra points on history that they feel. But what is important is that when you document the informant who's giving you the history at that point of time, it decreases inconsistencies on follow-up history. So let's say today the mother is giving you a history. So you've noted down that, the informant is the mother who's reliable. Let's say next time when the patient comes and follow up, the mother is not there with the child, and let's say the grandmother is giving you the history. So you need to also note down that, that history is being given by the grandmother, so that if there's any discrepancy or inconsistencies in the history that one person is giving versus another, it's because probably there are two different people, and, it all depends on who you eventually rely on more, and what actually fits into the history and the clinical picture. So this ends the video, and we've broadly looked at the importance of demographics. So remember these points. These can be asked as your Viva questions, and stay tuned for more videos on smaller topics that are very important for your OSCE and table Viva. Thank you so much for watching, and if you find this was useful, then please share and like the video. Thank you.